Thank you for being here. It's for the critical discussion of the health of our nation. Thank you to everyone who has worked so diligently to bring this session together, including Drs. Ding and Ajay, co-vice chairs of the task force. And while we celebrate our excellence in medicine during our annual meeting, we cannot do so without examining very real issues impacting our future. Since we have been here doing this meeting, there have been every day a report of a shooting. 1 in 5 or 21% of adults say that they have personally been threatened with a gun. 19% have a family member who was killed by a gun, including death by suicide. And to add to that, 17% have personally witnessed someone being shot. 4% has personally fired a gun in self-defense, and 4% have been injured in a shooting. In total, half or 54% of all U.S. adults say that they have a family member who have had one of these experiences. And guess what? I'm one of them. So when I was 17 years old, living across the lake in Gary, Indiana, my girlfriend dumped me. And after I got over my pity party, I decided that I would get a haircut so I can look better and look sexy and make her jealous. So I went across town to the barber shop, the one that I'd always gone to growing up. It was a weeknight, just like every other weeknight. So when I arrived at the barber shop, I learned that there was a shooting across the street, and the police had just left. A man familiar to me walked in, so let's just call him Joe. And Joe was an alcoholic. Why do I say that? Because he was drunk every time I saw him. But he was a likable guy for all that I could tell, and he seemed to be a great human being. So he began to tell the story about the guy who had just did the shooting across the street. He had just gotten out of prison, and he didn't care if he went back. Then all of a sudden, the door opened up again, and this man was unknown to me. He had begun to talk to Joe and to a barber who was a good friend of our family even. So the unknown man began to say to Joe that he would kill him for a nickel right now. And to be honest, this 17-year-old Willie was thinking, would you give him a nickel so he'll shut up? So Joe was reaching in his pocket to pull out a bottle, and he was putting his foot on the stool at the same time, and his foot slipped, and the guy thought he was making an aggressive move. So he grabbed Joe by the hood, put the gun to his head, pow, boom. And I'm like, what the? And then I looked up and I noticed that the guy had put the gun to the barber's head right between his eyes, and the gun clicked. Jammed. So then he walked out. So everyone in that room was frozen, including me. 6 foot tall, athletic wrestler, football player. I didn't move. I couldn't move. I couldn't even believe that this could happen. All I wanted was a haircut. And now that guy is bleeding. The guy walked out, walked up the street, and we could see a police car diagonally who stopped at the post office, at the mailbox there to put some letters there, and he's sitting there, and we're waving. So then the guy came back and tapped us and went like this, right? And then he sort of left and walked off, and then we called, and the cop whooped around and came back. So what we learned later, he got away, they caught him later, and what we learned that He left to get a shotgun that was around the corner, and he was going to come back and kill us all. This incident changed my life forever. No one should ever experience such a thing, especially a child. This is out of control. Firearms are now the leading cause of death in children and young people in the United States. Today's children are required to run active shooting drills because their classroom may be next. In the movie theater, in houses of worship, hospitals, big cities, small towns, gun violence have shattered the sense of security and have taken countless lives in the process. While mass shootings received a lot of attention, it is important to remember that the majority of firearms-related deaths are from suicide. And we are seeing the highest increase in death by suicide among younger people. In 1987, the AMA called firearms violence a serious threat to public health. And in 2016, we officially labeled firearm violence as a public health crisis. Our next 5 years, we embarked on an aggressive campaign to address the causes of gun violence and the fatal consequences. The AMA joined the American Foundation for Firearm Injury Reduction in Medicine, along with other leading healthcare organizations, to support research into the causes of gun violence, risk factors, and potential interventions. The AMA sent comment letters to the U.S. Senate Committee on Judiciary in support of extreme risk protection orders, which allows for temporary removal of firearms from individuals deemed a risk to themselves and others. We support state legislation to prohibit the possession of firearms in safe school zones, legislation in support of criminal background check for gun sales. Too bad we didn't have that when I was 17. Support for 17-day waiting period and the purchase and delivery of firearms. We develop education for physicians on their role in firearm injury prevention to increase their comfort and counseling of patients discussing secure firearm storage. But we need more. We need to bring together physicians who are vigilant and leaders who were prepared and are prepared to save this country and stop the violence. We need all of you and more. During our November meeting of 2022 annual meeting, the AMA House of Delegates adopted policy to establish a task force focused on firearm injury prevention. The task force brings together representatives from the national medical societies, specialty societies, federal agencies, other national organizations to advise the AMA Board of Trustees on the role of organized medicine in firearm injury prevention, and to inform the development tools and resources for physicians and trainees on firearm injury prevention, increase awareness of evidence-based interventions. We are lucky to have several task force representatives here today with us to share their work with us. The AMA has extensive policy recommendations to reduce firearm trauma, injury, deaths that have been developed and over the past 2 decades, including increased state and federal funding of gun violence research, improve the quality and comparability of timeliness of data on firearm injuries and deaths, waiting periods and universal background checks on firearm purchases, and the restriction in sales and ownerships to the public of all assault-type weapons, bump stocks, and high-capacity magazines. Despite our very gains on these areas, we must do more. People in communities, large and small, are scared. Our communities are suffering under the weight and the mental health consequences of gun violence. Parents and patients are worried that when their kids go to school, physicians are worried when they go to the office. We must do better. The task force is evidence of our commitment to a safer world and healthier communities. Thank you for the hard work and your commitment to these efforts. Today, our 4 esteemed panelists, which you'll hear from just a moment, will tell you more about their efforts in response to the nation's firearm crisis. After their individual presentations, they'll engage in a panel discussion, and then we'll invite questions from the audience. At the close of this session, we'll have closing remarks and final remarks from Dr. Ding. We all got a lot to cover over these 90 minutes, so let's get started. I want to close with this. All I wanted was a haircut. All people, when these shootings in these synagogues and churches and other places of worship, they just wanted to pray, just wanted to go to the movies, just wanted to go to a concert, just wanted to go to the park. We should be allowed to do that without fear. So let's work together. Let's make this happen. So let's welcome Dr. Lashay Ajay to the, and thank you for your time.
Thank you so much. Thank you, Dr. Underwood. It is clear that this is our lane. Before I introduce our panelists, I see that there are several members of our task force here in the audience. Can you please rise and be recognized? Please. Thank you for your time and dedication. You're members of this House of Delegates, and you give your time to our task force. Thank you very much. I will start by introducing our esteemed panelists here. I will not go into details of what they're going to talk about and let them give that introduction themselves. First, we have Dr. Emmy Betts, who represents the American Geriatric Society on the task force. Dr. Chetan Satya, who represents the American Pediatric Surgical Association. Dr. Catherine Hoops, who represents the Society of Critical Care Medicine. Dr. Ruth Abia, who represents Health Alliance for Violence Intervention on the task force. We'll start with Dr. Emmy Betts.
Good morning. Thank you all for being here. I was remarking as I got in last night at like 10 o'clock and the hotel was hopping. You guys are a crazy bunch. So thank you for being here this morning. My name is Emmy Betts. I'm actually an emergency physician, but I do a lot of work in aging research. So I'm happy to represent the American Geriatric Society. So when we were thinking about today's panel, we wanted to acknowledge just how complicated the issue of gun violence is, and that we couldn't in any way, shape, or form cover all of the nuances of it or the many promising approaches. And so we decided that I would present a brief overview of the public health approach, as well as sort of what gun violence looks like in this country as a way to ground our conversation today. When I say a public health approach, I think really means two things. Perhaps most importantly for our audience today, it's that we are approaching gun violence as a health issue. There are physical and psychological health consequences from firearm-related injury and death, and we should be approaching it as a health problem, meaning there are specific roles for all of us in this room today. But it also means that we are using the science of public health in how we think about this problem and how we approach it. This is an approach that has worked for everything from car crashes to infectious diseases. And so it's about, again, having a cyclical approach that is based in science. So basically, the public health approach has 4 steps that are repeated in a cycle. First, we use data to understand the problem, to look at the patterns of injury and death in different populations. We then identify risk and protective factors, understanding what are the causes of violence and recognizing that it's going to be different based on geography or demographics or the type of violence that we're thinking about. We then have to develop and most importantly, perhaps test interventions to understand what works for different populations for different types of violence. And then we want to scale up what works. So when we find promising interventions, we want to implement them on a larger scale. And then the cycle repeats so that we go back looking with data to understand how things are changing. A key thing that you're going to hear across the panel today is that for any type of gun violence in any population, we need tailored messaging and tailored approaches. We need to be working with the affected communities to make sure that the interventions we're putting in place are effective. So now, and Dr. Underwood alluded to some of the numbers already, but I do want to start with a little bit of data for us to be grounded in the epidemiology of gun violence in this country. I'm going to be presenting just fatal injuries. I want to acknowledge the many survivors of non-fatal shootings, as well as the psychological trauma experienced by friends, family, and the general public. But for data today, I'm just going to show deaths. And these next few slides all have the same setup. So the x-axis as age group in years, and then you'll see the solid line is the death rate per 100,000, and the solid area is going to be the number of deaths, just different ways of looking at burden. So the first graph is going to be comparing women and men. And what you can see here is that across all age groups, there's a higher rate and a higher number of deaths among men than women. And you can see the first spike in late adolescence to early adulthood, which is predominantly interpersonal violence, and then the spike in death rates in the older age group, which is predominantly suicide. So overall, about 86% of gun deaths in this country are among men. It's not to say that the deaths among women are not important, but just again, we need to start by understanding the patterns of death. So we can next look at race and ethnicity, and I want to acknowledge these are overly broad categorizations by the CDC. There's a lot of nuance here that won't be captured. These are now deaths among men by race and ethnicity. And when we look at the death rate, what should hopefully stand out to everyone and what should will continue to horrify us is the unacceptably disproportionately high rate of firearm deaths among young Black men, predominantly from interpersonal violence in the late teen to early adulthood. If you look at non-Hispanic white men in the purple, you'll see this sort of gradual increase over time, which is predominantly from suicide. And then when you overlay the population structure, what you can see is that the bulk of deaths are among non-Hispanic white men because the white population is bigger, such that overall in this country, about 60% of all gun deaths are among non-Hispanic white men, predominantly from suicide. But again, critically important for us to acknowledge that the death rate in particularly young Black men is disproportionately high. So this is how we start to understand what's happening in different communities and the different approaches and interventions that we need to be thinking about that might be effective in those different communities. So I've alluded to this already, as did Dr. Underwood, but what are the causes of, so not looking at populations, but what are the etiologies of gun deaths? In 2022, there were about 48,000 gun deaths total. And this is the picture. About 56% were due to suicide. Where I live in Colorado, that number is 73%. And I think I just want to emphasize that again, that over half of all gun deaths in this country are from suicide. We cannot talk about gun violence without talking about how to prevent those deaths. And it takes different approaches than it does for other types of gun violence, and that's okay. It's a complicated problem, and we can have complicated solutions. Another 40% in the U.S. of all gun deaths are from homicide, which includes domestic violence as well as youth and community violence. And then those so-called accidental shootings among kids, or the mass shootings that understandably terrify all of us, those are really only a drop in the bucket when it comes to total deaths. And absolutely, we need to be talking about them. We need to be working to prevent them. But we also have to be remembering the burden of gun violence that is happening every day in our homes and in our communities. So the next step then is to try to understand within each population what works and what doesn't work. And we could spend this entire session focusing on any aspect of gun violence or any specific population. So I just want to highlight kind of a few high-level things, and you'll hear more from the panel. So first, we can think about self-directed violence. That can be accidental shootings among children or among older adults with dementia. And it can also be from suicide, which is where most of my own work is. At the University of Colorado, we have a lot of programs going on working with the firearms community, with firearm owners, with the military, with rural populations, specifically to develop messaging and interventions that hopefully would be effective for those populations. And for suicide prevention, the key message is really about putting time and space between an at-risk person and a gun, because we know many suicide attempts occur very quickly after the final decision. And we know that suicide attempts with a gun are uniquely fatal. And so the message that we really push in this space, it's really twofold. So one is always storing guns locked securely, which is like putting your seatbelt on every time you get in a car, because you don't know what that day might hold. But then also recognizing when someone is at higher risk, you need to take additional steps to make sure that they don't have access to a gun, which is sort of like having a designated driver when someone is impaired. And again, I think across populations, what you'll hear today is how do we make these messages really resonate with populations? How do we work with affected communities to develop respectful and effective interventions? And that's true also when we think about interpersonal violence rather than self-directed. So that can be youth violence, community violence, domestic violence, partnership-related violence, or mass shootings. Across all forms of violence, access to a gun is a risk factor for death. But I want to emphasize it is not that the gun causes the violence. So in Dr. Underwood's story, imagine if that person had not had a gun, there might have still been violence, but there might not have resulted in death. What the gun does is escalate it and significantly increase the risk that a serious injury or a death will occur. And so again, that's where I think we really need to continue to recognize that it's about emphasizing secure storage at all times across the board, making sure unauthorized people, including kids, don't have access to guns. But then also when someone has acute risk of harming themselves or others, that we take steps to make sure that they don't have access to a gun, whether that's voluntary approaches, which is where a lot of our work focuses, or involuntary approaches like extreme risk protection orders, which you'll hear more about. And then the last step is, which is really important as well, is to scale up. How do we think about engaging broader health systems, which you'll hear about today, businesses, communities? How do we take effective programs and make sure that they reach broader populations so that then we can continue the cycle and hopefully see a bigger impact? So I'm now going to turn it over to the rest of the panel. Again, we hoped that this kind of grounding in a public health approach will acknowledge that we're not going to be able to talk about each bucket in this very complicated and messy picture. But this is the kind of science that we use to ground the different interventions and different approaches that we're working with. Thank you.
Thank you, Dr. Betts. Is it this? Just laptop? Okay, perfect. So my name is Chetan Sathya. I'm a pediatric surgeon. Really wanted to say a huge thank you to the AMA for putting together this task force, bringing us here today to discuss this issue. As you heard from Dr. Underwood, right? These kind of conversations at these big conferences are not the norm. And so just by having this conversation, it means a tremendous amount, not only to the community, but really in moving us forward. So thank you. I just wanted to tell a brief story because every time I come back to Chicago, this is very much my second home. I trained at Lurie Children's just down the street. And, I got brought into this movement as a pediatric surgical trainee at Lurie, where my first week on the job, I treated this 6-month-old with a bullet wound. And I'm Canadian by background, so this was my first move to the United States. And I had not treated an infant with a bullet wound before. And for anybody in pediatric trauma, you know that the parents come into the trauma bay with you. So you can only imagine this experience as a pediatric surgical trainee. I had this little baby girl, 2 beautiful earrings, bullet wound through and through the abdomen and pelvis. And I just remember the blood on my fingers, her eyes rolling to the back of her head, and the horrific expression that the parents had in that trauma bay. And you can't help but think about your own kids, your families, and that these parents kept saying over and over again, they never thought it was going to be them. This little baby girl survived. I still keep in touch with the family, but she remains paralyzed to this date. Really speaking to an issue that Dr. Betts brought up, right? That 80,000 to 100,000 Americans are non-fatally injured by guns, and this results in significant disability. Unfortunately, that wasn't the last time I saw that, not only in Chicago, but in New York, where I work now. We are the largest level 1 pediatric trauma center in New York, and we see many, many kids injured with gun injuries. In fact, in 2022 and 2023, compared to 2021, we had a 350% increase in the number of kids coming in with bullet wounds. Some of these kids come in with failed suicide attempts. Some of them are toddlers that are shot sitting in a car seat, or kids that are just in a bad community. We see the whole spectrum. So I was really inspired when I started my journey at Northwell, which is the largest health system in New York. We have around 28 hospitals. I started there in 2019. And immediately when I started, I found out that our CEO was taking a big stance on this public health issue. And at the time, I was naive, right? I'd been a surgeon. I knew many of us physicians were activated on this issue. Until our CEO took a big stance on this topic, I didn't realize that he was actually one of the only large health system CEOs to do that. And he said that he's going to prioritize gun violence prevention at a hospital administration leadership level, at the same level that we want to tackle cancer prevention and heart disease prevention. And I bet that most people in this room can't tell me of other leaders that had done that at that time. Fast forward now, momentum has grown, right? Dr. Betts talked about some of the stats. There is optimism. Many health systems have joined the cause. Numbers are going down thanks to many of the efforts of panelists here and everyone in the room. And so there is definitely an optimistic story here. As mentioned, we're going to get into a lot of the nuance of this issue in the panel, right? Dr. Betts set the stage, so this is meant to be very brief and broad. We started a Center for Gun Violence Prevention after his call to action in 2019, so we started that center in 2020. We have over 100 different initiatives. We do work across the spectrum. We have different groups, and the point here is just to highlight, if you're at an institution and you're figuring out how to structure something here, this is a nice little blueprint. We work on gun violence strategies that span working with community partners, whether they be law enforcement, gun owners, hospital-based violence intervention programs, CVI groups, faith-based organizations. We have a public awareness arm. We focus heavily on not only the New York market, but the national market when it comes to public education on what gun violence prevention means. We have a policy and advocacy arm, very much focused on public health policy, a research and clinical arm, and then a medical education arm. We have integrated gun violence prevention education into our curricula for our medical school, our residencies, and our providers. Because at the end of the day, we can't actually screen our patients or actually work with our patients on gun violence issues unless we're educated on it. So, I'm happy to go into more detail around this, but this structure has really allowed us as a system to comprehensively tackle this issue. One point that I wanted to hammer just in our research realm, and something that we instituted right when we started the center, is we began a universal screening program. And the reason being that, and this doesn't mean it's the right fit for every place, but I just want to paint a picture. When we first delved into this, I asked myself the question, why is it that most providers, healthcare workers, don't really talk to their patients about gun injury risk, right? It's just not commonplace, even among trauma surgeons. You see pediatricians do it quite a bit, but even among the pediatric community, it's not commonplace. And then when you look at other specialties, it's just not something we routinely learn about. So we came together with some of the addiction services specialists in our system and tried to look at what kind of approaches worked the best when it comes to normalizing the conversation and integrating it into usual or routine care, just like you ask about exercise, smoking, and other risk factors. It was really the substance use model of SBIRT, screening, brief intervention, then referral to therapy, that we leveraged to implement a universal screening program across our system. And whether it's right or wrong, the research is coming out, I'll talk about it a little bit later. We went from not really screening ever to now screening 50,000 patients yearly. And this has become part of our culture. And a very important note there is when I talk about screening, our questions ask about firearm access, and we also ask about gun violence risk. There are questions out there, right, like the safety score, that can predict someone's future risk of community violence. So we ask both those questions. And the reason I bring that up is that we actually offer a comprehensive screening approach that we have found in our research so far brings families to the conversation because they understand that we're looking at this with tremendous nuance. To Dr. Betts' point earlier, gun violence could mean firearm suicide, it could mean community violence, it could mean unintentional injuries, it could mean a school mass shooting. It could mean that to any American in this country. But the policies and interventions that are required to stop those different types of gun violence are very, very different. So if you start, in our experience, if you start just screening and asking only around access, for example, with some families, and they live in a community that is riddled with community violence, we've gotten feedback that that is not actually necessarily in line with building trust with that family. Versus if you screen for violence risk only among a suburban gun owner, let's say, that also might not resonate. So actually by tackling the whole issue, we've had 50,000 plus productive conversations, and it's offered a opportunity for our system to really integrate this into our usual care. So whether you come in with belly pain, a headache, urinary tract infection, you get questions around gun violence risk, just like you get screened for other things. So that's one of our big projects that we'll dive into a little bit later. On top of that, our big focus of us has been hospital coalitions. I know you mentioned that, Dr. Betts, but really healthcare leadership stepping up, joining us on the front lines is important for sustainability. It's important for our programs to actually get off the ground. So we'll talk a little bit later about some of the coalitions that we have. We have a 600 hospital coalition that's focused on implementing and scaling some of these practices across your institution. And we have a new CEO council that's focused on committing at big health systems to actually putting money behind these programs, which I'm happy to talk about when we go more into detail about the business case and so on. So thank you for having me here. Looking forward for the discussion.
Hey, y'all. I'm Catherine Hoops. I'm a pediatric intensivist at Johns Hopkins, and I also lead our clinical programs and practice team in the Center for Gun Violence Solutions in our School of Public Health. Thanks to all of you guys for being here today. Really appreciate you being here listening and wanting to be a part of the solution with us. So I also want to start with a story because it's not often that I, as an intensivist, get to sit at the bedside of a young person who attempted suicide using a firearm, right? As y'all likely know, the case fatality rate for firearm suicide is over 85%. So most of these patients, young people, are dying before they make it to the hospital. But once, a long time ago, a mom said some words to me that'll stay with me for my career. And so I hope that they'll resonate with y'all as well. So this was a 14-year-old, beautiful young girl who was being bullied at school and treated for depression. She was close with her family, very devoted. They were getting her access to mental health services. She was seeing a therapist and a psychiatrist. She'd started on medication for depression. And again, she was really close to her family, and they felt like she was getting better. Until one day, she accessed a firearm in their home and attempted suicide. And so as I sat at that bedside with her mother, knowing that she wasn't going to survive her injuries, her mom said to me, "I wish someone would have told us to get the guns out of the house, because we would have done that. And then she'd still be here." And I share this story because I think it helps to illustrate why each phase on this pyramid matters and is important, right? So like we just talked about, safe and secure storage is the foundation, right? That's kind of a central tenet of responsible ownership, that we're storing guns unloaded, locked, separate from ammunition, and her family was doing that. They were already doing those things. But then, at higher levels of risk, higher levels of protection are required. So that's where lethal means safety counseling and assessment comes in. And I'll say, many of us as clinicians are not trained on lethal means assessment, are not trained to provide lethal means safety counseling. But we hope that through educational program building like this, we can start to talk more about getting more people comfortable and confident delivering this kind of life-saving counseling. So what's the difference between just, general counseling on safe and secure storage and lethal means safety counseling? Again, safe and secure storage is the foundation, something that we might be talking about in any well child visit or in any general injury prevention anticipatory guidance that you're providing. But then lethal means safety assessment includes screening for risk for suicide, screening for access to lethal means, and then providing additional counseling to help to mitigate risk if that's indicated. So if there is a firearm in the home and someone is at risk for suicide, you're talking about maybe getting the firearm out of the home through a voluntary transfer to a trusted family member or friend. You might be talking about off-site storage, like at a shooting range or a gun shop that offers safe off-site storage for a temporary time. You might just be talking about making sure that an at-risk person doesn't have the code to the safe or doesn't have access to the key for a lock. Or you might be talking about restricting access further through extreme risk protective orders. So I have to shorten it for the pyramid, ERPO, but an extreme risk protective order is a civil order that can be petitioned for by a variety of potential petitioners. In some states, clinicians are included as direct petitioners, such as in Maryland, where I live. But in all states that have them, law enforcement can petition, and family members can petition in many of the states. So I'll come back to some of the resources for clinician petitions and for us to engage in ERPO, but want to share first kind of what generally they are and when you might consider using them. So again, these are civil orders that allow law enforcement to go into a home and remove all firearms to which the at-risk person might have access. There's due process. There are multiple hearings before there is a hearing to which the respondent presents before the final order is issued. And not all of the orders that are petitioned for are implemented. But these allow firearms to be removed from the home, and a person is prohibited from purchasing new firearms or having access to firearms during the period that the order is in place, which is usually a year. Now, they can be removed sooner if the critical time period passes sooner, or they can be extended in some cases for a limited amount of time. But these have been shown to have potent reductions in suicide, also homicide, and also some fatal mass shootings, even though we know that those events are unacceptably common, feel all too common, but are statistically rare. We do still see that these can be used to prevent fatal mass shootings. So ERPO are a great tool for preventing suicide if someone is known to be at risk. But I want to highlight that this is not the same thing as lethal means safety counseling, right? Not everyone who has access to a firearm, needs to receive lethal means counseling. Not everyone who might have endorsed, thoughts of suicide without, more imminent risk of harm qualifies for an ERPO, right? So each step on the pyramid is really important, right? That foundation of safe and secure storage, lethal means safety counseling for those at somewhat higher risk, and extreme risk protective orders are reserved for those at imminent risk of harm to themselves or someone else. And then, emergency petitions, I put EPs, again for short, at the top of the pyramid, recognizing that that's really, even though ERPO we think of as being the most restrictive means of lethal means safety in terms of restricting access to a firearm. But of course, emergency petitions restrict so many more potential civil liberties and freedom of movement. So that's really the most restrictive means of suicide prevention, with ERPO being the most restrictive means of lethal means safety. So I want to share a resource that my colleagues in the Center for Gun Violence Solutions, in partnership with the Department of Justice and the Bureau of Justice Assistance, have put out for a whole lot, for everyone, really. There's something for everyone on ERPO.org. But this is the website for ERPO.org. It's easy to remember. You don't need to pull out your phones now. But really, this culls a lot of the expertise on extreme risk protective order implementation and research that has been developed over, really the last 15 years, almost 20 years, since ERPOs were originally starting to be adopted. So ERPO is really conceptualized through the Consortium for Risk-Based Firearm Policy, and some of the founding members of the consortium can remain really active in ERPO implementation and ERPO research now, and are some of my colleagues in the center. So this calls all of that expertise to now have this resource for all 21 states and DC that have ERPO laws and potential petitioners in each state, but also for other states that are considering advocacy for an ERPO policy in their state or resources on implementation in other states as well. So what is included on ERPO.org or the ERPO National Resource Center? It's a training and technical assistance site, right, that includes resources on legislative history, the statuses that are included in each policy, processes for each state, and most importantly, local toolkits that are produced by local stakeholders to allow local potential petitioners to engage in the process. So I highlight here just kind of what it looks like, but you can go for any state that has an ERPO policy, and you can learn more about how that law was passed, specific provisions of each law, and how you might engage in petitioning for an ERPO if you have a patient who's at imminent risk of harm to themselves or others. Also highlight a couple of resources in the ERPO Resource Center library for clinicians. And here now you can pull out your phone to access this resource sheet that has a lot of really helpful fast facts on ERPO for clinicians and for the general public as well. And then a couple of training opportunities. So this the ERPO Coursera course includes specific modules for clinicians. I would encourage you, if you do go to the Coursera course, just focus on the clinician modules because some of the other material is a little bit dated, but these I think are continue to be really helpful. And this is a view from one of the videos that we developed for the ERPO Coursera course. It helps to provide language for clinicians on how to talk to patients and families about ERPO. Right, to model those conversations, whether it's a clinician who's petitioning, or it's a clinician who's engaging with law enforcement, or a clinician who's partnering with a family member to petition for ERPO. And it helps to model some language that you might consider using so that you're engaging in what might be kind of a challenging conversation or something that you're nervous about doing the first few times. But it helps to provide some sample language that hopefully can that will resonate and be useful to you as well. There's also a CME activity on in the resource library. It's about a 45-minute module that has more detail on ERPO and the history and the statistics that also I hope you'll find useful. But again, I think that the message that I want everybody to take home is that ERPO isn't applicable for everyone, right? ERPO is for those who are at imminent risk of harm to themselves or others, but they are a really important tool when we do have a patient who's at imminent risk of harm to themselves or others. But in general, we need to be developing tools and processes to help us identify that hierarchy of risk and develop solutions at each level in the pyramid. So thank you guys. I know we can get into some more of the details during the Q&A.
I just want to echo the thanks of my colleagues. My name is Ruth Abaya. I'm a pediatric emergency medicine physician in Philadelphia, trained right here in Northwestern down the street many, 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 many years ago. So it's great to be back in Chicago. I'm going to pivot a little bit to talking about community violence and HVIPs. And I'm also going to start with a story because I think the stories are so compelling and are what brings so many of us to this work. So when I was a fellow in Philadelphia, I took care of a young man in the trauma bay during my trauma rotation who had just been in the trauma bay a few weeks before, such that the trauma surgeons all recognized him. He had some significant disabilities from his first shooting injury and was back with yet another shooting injury that he was going to survive. And it felt like such a moral outrage that we were going to send this young man right back to the exact community, circumstances, relationships, lack of opportunity that would predispose him to yet another likely fatal injury. It felt, I think, completely unacceptable to everyone who was caring for him. And for me, as someone who had training in public health, it felt really critically important that we think about the upstream preventative factors that might actually avoid this kind of recurrent injury, which was all too common in the city of Philadelphia at that time. So in my background, I've worked in pediatric emergency medicine. I ran our local health department's injury prevention program, which was the first time that the health department had committed effort to this problem, which is shocking in a city like Philadelphia. And from that, really became committed to the idea of public health approaches to violence in a city where all of the approaches to violence thus far had been criminal justice based. So I want to talk a little bit about what community violence is and what HVIPs are.
And so HVIPs are hospital-based violence intervention programs. I serve as the Senior Director for Health Systems and CVI Integration at the HAVI, the Health Alliance for Violence Intervention, which is the only national organization that fosters the development, implementation, and evaluation of hospital-based violence intervention programs. These programs are unique because they are designed to begin in the hospital setting, at the bedside, classically, engaging people who have suffered a violent injury and using staff that are violence prevention professionals. Often they have lived experience, they are from community, they have a very thorough understanding of the drivers of violence, and these same incredibly talented and committed caseworkers follow patients into community to provide comprehensive case management for up to 6 months. 6 months is our standard. Often it's much longer than that. It's rare to have a model of care that actually begins at the bedside and continues for that long, using that opportunity, that kind of critical teachable moment to launch a transition and a transformation of someone's life course after a violent injury. So that's the kind of spirit of HVIPs. HVIPs are part of community violence intervention. And community violence intervention, I would say, even though it's very old, older than I am, is an emerging field because it's new for this area of research and practice to actually be funded. Many of you are familiar with the long-standing inadequate funding history for all kinds of gun violence, but certainly community violence intervention in particular. And so as there have been an increase in funds in this area, there's been more attention to kind of clear definitions about what community violence is. And I really want to go through that very briefly. Community violence, and we talked about the fact that there are all these different manifestations of gun violence. Community violence is generally described as interpersonal violence between people who are not related, often in public spaces, very commonly involving a firearm. CVI, or community violence intervention, is really focused on a few key features of community violence. It's usually concentrated. There's plenty of research, a lot of it done right here in Chicago, that demonstrates that community violence tends to happen in particular geographic locations. There's also very compelling and disturbing research that shows the overlap between those concentrations and historical racist practices in how communities are built. So we know that there's an overlay, and that leads directly to some of the statistics you saw about who is disproportionately impacted by rape. Community violence is also cyclical, meaning that it has a retaliatory nature. People get shot, they shoot in retaliation, and you get into the cyclical pattern. It is networked. Again, a lot of the very robust research on that was done right here in Philadelphia by some experts at Northwestern, demonstrating that there are very strong connected social networks between people who are engaged in violence, and they make up a very small percentage, not just of the city's population, but even of the population of people in communities most affected. It's a very small number of people that are engaged in a cyclical pattern in violence. And so that gives us a target population, right? That gives us our triage. That gives us who we need to engage to meaningfully change the needle. And then it's also preventable. And that may be the most important part. So because it's so entrenched, because it's so cyclical, it's easy to have a kind of fatalistic and pessimistic perspective on community violence. But it's absolutely preventable. And there are lots of strategies that do exactly that. And that's what CVI is. So HVIPs, of all the CVI strategies, is the one that's really intended to start where we all work, start at the bedside. And a lot of times, the types of services that HVIP experts are providing really address the upstream drivers of violence. And so if you take the example of the young man I told you about before, you take people who are engaged, for example, in the very robust drug trade in the city of Philadelphia. If he has no other viable options for employment and housing, he's going to go back to that. Providing an off-ramp so he has actual opportunities for safe employment, safe housing, potentially removing him from that networked community that is engaging in violence in a cyclical nature, that's what could save his life and provide him sustainable change. So housing, victim services compensation assistance, safety planning, helping with retaliation and interrupting violence. And that's another strategy, but a lot of violence prevention professionals have that expertise as well. Education assistance, job placement, legal advocacy, transportation. A lot of HVIPs are deeply dedicated to mental health resource provision because there's a lot of unaddressed trauma in a lot of the people who are victims of community violence, substance abuse counseling, and much more. And so this is the strategy. You start with an immediate bedside intervention. You allow medical care to proceed with that partnership with an expert who has violence prevention professional training. You provide follow-up services in this myriad of spaces, both within and without of the hospital. And then you address all of those social determinants to hopefully provide an off-ramp for participants. I do want to keep it brief, but I'm going to end with one another more optimistic, very brief story of a young man who was a member of an HVIPs, who had consented to receive HVIP services. His life was very complicated. He did not have a stable housing situation. He had been kicked out by his mother. He had a chronic disease for which he had a medication he could not miss, but he had no resources to get his medication in a consistent way. And the person who was holding all of these pieces together in his life was his violence prevention professional. This VPP was helping him go to the pharmacy and get his medication, taking him to school and advocating for him to get all the supports he needed in that space, helped him navigate and mediate a relationship with his older sister so he could live with his older sister when he was kicked out of his mother's house, and helped him eventually, after many months of engaging him around the subject, actually accept therapy and start to engage in the road of recovery. So I had a first row seat to this individual's powerful work in this young man's life, and it was transformative. This work is incredibly important, and it's right where we live. So I'm very excited to talk more about it and more about CVI in general and the roles that we can play in that work. Thank you so much.
Thank you. Let's give our panelists one more hand of applause. I'm going to have you guys turn on your microphones. Probably, let's see what happens if you guys turn them all at the same time, if we get any feedback. As we engage our panelists in Q&A, this will be the opportunity to hopefully give you guys some tools to take back to your institutions, your home institutions, as we engage in some questions. And I really want to start with Ruth. You know, a number of states are using Medicaid dollars to pay for community-based violence programs. Do you think this is something that can be replicated within other states? And can you talk more about this?
Sure, absolutely. So, can you hear me?
I could also just talk really loud if that doesn't work. Does that work? Yeah? Okay, great. So happy to talk about this. So many of you, I'm sure, have engaged in or have maybe had some preliminary conversations about how to get your hospital to invest in the types of programming that you would want to do for survivors of violence, right? Because we're at the front line. We see these patients, we want to do more, but we have to make a case for that. So there are a lot of tools that we can use to successfully make that case. I'm going to make 4 brief points around that. I'm going to end with the Medicaid question. So the first is something that your hospital leadership is probably very well aware of, which is that violence is extremely costly. So the most important cost is the human cost. And I think for all of us, given our mission as physicians, that should be front and center, right? It's hard to actually put a dollar amount on what it means to communities and families for violence to occur. But there's a huge financial cost as well. We know that billions of dollars every year in the United States are spent on violent injury, an estimate of over $900 billion in 2020, according to the CDC. We also know that a large proportion of violently injured people, especially in the field of community violence, are uninsured or underinsured. Many of them are on Medicaid. And so there is a huge gap as far as actual reimbursement for these types of injuries. It's extremely costly for health systems, not to mention the cost for families themselves. And that's just talking about medical costs. We also know that when you look at the evidence around what the median cost is for an injury, there's a range. Most of them are in the, well into the mid 5 figures. And a lot of those costs, at least 60%, are those upfront hospitalization costs. So it's costly, and that's an important case, I think, for hospital leadership to understand. The second case I'll make is that there are other benefits to the health system beyond just thinking about financial reimbursement and sustainability, which is something that Medicaid can certainly help provide. And so most nonprofit hospitals have an obligation to think about their community benefits in response to a community needs assessment. Having something like a hospital-based violence intervention program and having robust programming helps them meet that obligation, helps them be a good neighbor, but actually meet that formal IRS obligation. So that's another case that you can make to your hospital system. The third point I'll make is that for those of you that are in trauma centers, part of your trauma verification includes taking optimal care of your trauma patients, and having programs like HVIPs can help you meet that goal as well. And so that trauma verification requirement can be met by having programs that respond to the needs of violently injured patients. And then I'll end with Medicaid. So for states that have opted into Medicaid expansion, that provides all these opportunities for that state to make decisions about reimbursing services provided to violently injured patients, such as HVIPs. And so in states like Pennsylvania, where I practice, violence prevention professional services are reimbursable. Now, these are not large streams of income, But what it does is it provides an opportunity for sustainability. So if you can reimburse the services of your frontline providers, that's a consistent stream of revenue. You don't have to reapply for it in most states. That's a consistent stream of revenue that provides a baseline for what services you're providing for violently injured patients. And then your HVIP doesn't have to be entirely dependent upon grant writing and the on and off kind of spigot of federal funding that might or might not come. So this provides a level of sustainability that's really critical for your HVIP to be able to provide sustained services to your community. So we've provided some resources to the organizers for this panel for all of you to look at. We have a position brief around Medicaid reimbursement for the services provided to violently injured patients. And there's also some tools that help you do some calculations for your state around what you might be eligible for.
Thank you. And I'm curious, Chetan, can you actually speak to a larger business case actually about this?
Yeah, absolutely. So, that was excellent. Just to double down on a couple points, I think the Medicaid differential in what a hospital gets versus what they spend, is just exorbitant when it comes to gun violence patients. And we've definitely found that with health systems that resonates with a lot of CFOs and helps you make that business argument, which unfortunately you have to make to administrators. They're not always having the viewpoint that we have. The community benefit thing is spot on. I will say when we think about community needs assessment, depending on where your health system is, or for example, where our health system is, we do see the whole spectrum of different types of firearm injury. So that community needs assessment does and should include all types of gun injury, right? Whether it be firearm violence, community violence, suicide, unintentional injury. And that should really, really guide, I think, a lot of the conversations that you end up having with hospital administration. We have seen some hospitals not do that in the right way, and it just ends up being tone deaf with administrators. So let's say you live in a community, right, like Dr. Betts, right, or you're in Colorado and you have a high rate of firearm suicide. If you work at Intermountain, where their focus is very much on suicide, versus if you work at University of Chicago, different things are going to resonate with different community partners. So that community needs assessment should be broad. I will say also, engage and listen to the community. Right, in your community needs assessment, work with the community, understand what they want from a health system, and bring those community partners in to talk to your administrators. We have found that exceptionally powerful. At the end of the day, that does move and sway minds, often far more than we might be able to as physicians, because the community is what that health system serves. Those were, I think, the main things I would say for making the business case.
Thank you. I want to pivot to talking to patients and counseling them. I am a pediatric and adult palliative care physician, and oftentimes when I am seeing families and patients who are victims of firearm injury, sadly, the conversations that I'm having are a little bit too late. And I could share stories, but I think you guys have heard those stories, and mine are a little bit too sad. And I'm curious, as I look around this room, there's a wide spectrum of patients that you guys all care for. Those could be responsive to secure storage. And I'm just curious from the panelists, for those who maybe new or uncomfortable to talk about some of the techniques that you talked about, what advice do you have about talking about secure storage or anything that you guys have talked about so far? Amy, go ahead.
Yeah, thank you for that question. So I think it really comes back to remembering why you're having the conversation, which is the common goal of health and well-being. So, I will preface this with maybe my own story, which is I'm not a gun owner. I don't come from a gun owning background. I have many friends and family members who are gun owners and enjoy hunting and so forth in the West. But I think I've been able to successfully build some really incredible partnerships with the firearms community because I've always approached it from the perspective that nobody wants their kids dying. Nobody wants suicide in their family. Just because someone owns a gun doesn't mean that they're okay with someone being killed with it. And I really think that we as a profession need to acknowledge how I think really we've been demonizing gun owners, and we need to stop it. Because it's not going to help anything. If we truly care about preventing injuries and saving lives, we need to be working with patients in ways that are effective and respectful and acceptable. When we have someone, I think back in medical school when I was trained on how to ask about sexual activity, and I was very giggly and embarrassed, and it felt really awkward. I don't even think about it now in the ER, right? I talk to people about everything from lifestyle choices to perhaps problematic behaviors related to substance abuse or alcohol abuse, to other kinds of lifestyle issues, to think about the various religious kinds of things that we may interface with in patients around blood transfusions and so forth. We are trained in medicine to work with patients regardless of their backgrounds, regardless of their beliefs, to help promote health and well-being. And that's what we need to be doing in this space. And I think it takes maybe taking a moment to check your own biases, and then really don't be afraid to acknowledge what you don't know. You don't have to be an expert. You don't even have to know what the storage options are. But I think when you enter into these conversations in a way that is thoughtful and respectful, it can go a long way. And I think we also just need to recognize, according to national statistics, 40% of homes have a gun in them. I think it's probably higher because a lot of people are not being probably honest. And so if you think about half of your patients probably have a gun at home, it's time for us to stop sort of being so nervous about it. We just need to normalize these conversations. And we have a very strong case to make in terms of secure storage and making sure unauthorized people can't access guns, and then in times of risk, that gun access is reduced. I do want to say, for communities at risk of interpersonal violence, youth violence, like the work Dr. Abaya is talking about, I think those conversations are different. It's not just about locking up guns. It's about the kinds of assessments to understand what other services someone might benefit from. But honestly, I think we just need to get over ourselves and and be good listeners and be good people and talk with our patients.
I mean, I think you might be a palliative care physician and you don't even realize it.
I do love geriatrics and palliative care also, yes.
Catherine, look, you wanted to say something.
I honestly, really just to say that I agree. That looked more promising. A light turned on. Great. Okay, there we go. No, really, I'm just in total agreement. I think that, I don't know if you can detect the accent. I'm from Alabama. I'm from a military family. I'm a lifelong gun owner. And that's absolutely informed how and why I do the kind of work that I do. And I couldn't agree more. I think that, one framework that I think really helps is to just ask more questions than solutions you're trying to prescribe. Try and understand more what someone's rationale is for keeping a gun stored the way that they currently have it stored. And then rather than trying to prescribe some one-size-fits-all, store all of your firearms in a movable wall safe in your basement with the ammunition stored separately, right? Like, that may not resonate with someone who owns a firearm for personal protection. And, rather than trying to, give someone a bunch of evidence about defensive gun use, really just try and partner with them, ask more questions, try and understand where they're coming from, and then come at a mutually agreeable solution. I do think, education helps, though. And, like you said, check your biases. Educate yourself on types of safe storage, how to implement safe storage at home, and then go into it with a attitude of appreciative inquiry and try and understand your patient's perspective and come up with a solution that fits.
That's true. I think education is important, and you can't educate if you don't screen for who needs that education. And Jathan, you talked about a little bit about this in your intro. Can you expand on this a little bit more? And maybe about large-scale implementation on screening.
Yeah. So I just wanted to, again, just emphasize, I think that was spot on, right? We can't vilify any group. I think that as a profession, both of you are very right. I think we have, I often lacked empathy for why somebody might, let's say, own a gun. Or somebody might have a feeling about something. It doesn't mean that that person is an evil person, right? And we see this dialogue in public health discourse all the time. So you have to actively fight against that. I would say that actually very much relates to large-scale implementation. So as you create a narrative in your organization, you have to have that centrist view. You have to, have common sense and empathy for all opinions. And so I think first and foremost at an organizational level, to scale, how do you create a sustained dialogue across an institution? So understanding what people are doing across your institution, what are their feelings, that's not a hard thing, that's not an easy thing to do. But with the appropriate leadership buy-in, you can start. And it is that dialogue that will change culture. That's certainly what happened for us, because people started to voice their opinions. They started to ask more questions. And that's what led us into our educational campaign to be able to implement this type of screening. Education, key. Everyone mentioned it here. We have ongoing education as part of all onboarding at Northwell. You need that education, otherwise people, not only will they not screen, they won't understand why you're doing it. And in the process of education, we adapted a lot. We realized that our education was often not correct. We weren't approaching it the right way. We were getting a lot of feedback. I will tell you, the most resistance we got at our health system in implementing the screening was not from our board, even though they were resistant, not from our leadership. It was actually from fellow physicians who, and I see a hand pointing there. It was people not only saying, I don't have time for this, but that why are we doing this, right? So I think we have to have humility and understand that we are a diverse community that doesn't think like everyone in this room probably. And so approaching that conversation requires a lot of openness. So education, scaling wise, I think you always have to think about just simple implementation science as you embark in this journey. Not only usability, but what are the barriers to adding yet another screening protocol and intervention. As I mentioned earlier, we screen for firearm access and violence risk. So if you screen positive for access, we give firearm safety counseling, gun locks, some local resources with gun ranges and so on. And if you screen positive for violence risk, we preventatively try to offer a staggered CVI approach that was mentioned earlier. Not the full-blown approach, but we have actually had a number of kids who have been prevented from being shot with that approach, right? Because if someone lives in a community where their brother's already been shot and in an HVIP, that child is probably at risk as well. That approach really required, that can be labor intensive. So the way that we overcame a lot of barriers when it comes to implementation and scaling was EMR integration, using technology as much as possible, not taking up physician time. So very much a team-based approach that includes nurses, social workers, and physicians and residents. Kind of a Swiss cheese model. And then when we can, we're also piloting patient-facing screening and intervention, which is also effective. So you have to adapt with all these things in your different settings.
I want to make sure that we have time for some audience questions, so you guys have time to ask our panel experts some questions. And I see. Let me have the panelists conclude with one final question, and then I leave it open it up to the audience. So before I open it up to the audience, I wonder if each of you can actually leave us with some practical advice on how we can leverage data to effectively advocate for policy changes and mobilize our colleagues along the various specialties that we work with and political backgrounds to actually participate in firearm injury prevention efforts. So Ruth, I'm going to start with you and then just kind of go down the line and end with Chetan.
Sure. So I have a couple of thoughts. I am going to say, so we didn't have time to get to this topic, but I do want to say, because it was mentioned before, I hope we don't get used to this new statistic about firearm injury being the leading cause of death for children. We are all very used to what the leading causes historically have been, and we say them without thinking about it. But I really just want to make sure that that lands with the appropriate gravitas. It is such a discouraging feature of our society relative to peer nations that I think is really an important galvanizing moment for our field. But I do think that there are ways forward, and data is one of them. So I will kind of pivot right to that. There are three ways that I think I would love to see data used more robustly in specifically community violence intervention. The first is using internal data. You would be surprised how many trauma chiefs, emergency medicine chiefs don't know how many violent injured patients they saw in any time frame or anything about them. What part of the city did they come from? What were their injuries? Where did they come back to the hospital? How often were they re-injured? What parts of the hospital were they seen in? Did they come back to mental health? Did they come back to trauma follow-up? How can we engage them? A lot of the internal data goes unused. And so a robust exploration of internal data to understand your own health system's violence problem is how you should really build any violence intervention strategy, because it should be informed by what you see. The second way is external data. So I also think that there are a lot of us who do a lot of violence work who don't know what other data sources are available around the epidemiology of violence in our area. And so there is law enforcement data, there's public health data. These are partners that we need to work with if we're going to understand the scope and nature of the problem and how it's changing. Those were the sources of data that first told us in Philadelphia how suicide was changing in Black youth. And so we need to understand those trends on the ground in real time so we're not answering a problem that's 5 years old. And then the third way that I think we need to think about data is integration. And so how do we actually bring all of those data sources together for a comprehensive look at the problem? I don't think that there has been great practice universally, because there hasn't been a lot of precedent for this, in integrating health and criminal justice and other sources of data to really better understand the problem. But the first tenet of the public health approach that you all heard is to understand the problem. And we can't do that if we're shooting in the dark. So it's really important that we have internal data, external data, and integrated data if we want to try to build programs that actually meet the needs of our communities.
That's great.
I think my advice is pretty simple. We know that policy matters. We know that policy can help to prevent firearm deaths. Like a person in a state with less protective firearm policies is 10 times more likely to die than a person living in a state with more protective policies, referencing, Mississippi versus Massachusetts with more protective laws. So I guess what I would encourage people to do is to reflect and to tell your patient stories. Right? Like we heard, we all have stories that can inform advocacy, and advocacy that is data driven. So I guess I would just encourage people to go to your lawmakers and tell your stories, tell your patient stories, and then use that to help start a conversation around one of those evidence-based policies that we know work. That might be an ERPO law, that might be a child access prevention law, that might be licensing or some other policy that's based strongly in evidence and is known to reduce firearm injuries. But I guess that's my advice. Tell your stories.
Emmy?
Yeah, I would echo what they said, and I'm going to add on maybe a little bit more of almost qualitative data, in that I'm probably counting on my fingers still, but over the past 5 to 10 years, there has been a really remarkable increase in engagement from the firearms community, especially in suicide prevention and secure storage messaging. And I think, although it's hard to quantify yet, it's really important, because it's about spreading the sort of cultural change that we need around having secure storage be part of responsible ownership. And I think it's relevant for medicine, because it means there are a lot of resources now, messaging coming out from the firearms industry and from the firearms community. So it's not doctors finger wagging. These are materials and brochures around secure storage that are coming from within the community, and I think that's incredibly important. And I think I don't know how we will quantify it moving forward, but I think it's an important thing for us to keep our eyes on and really applaud and sometimes perhaps leverage for our own use with patients.
Thank you. Jathan?
Yeah, just very quickly, the point for folks that don't know, right, the data we have on gun violence injuries in this country is very, very poor when it comes to being real-time and comprehensive. To the point that you often see the Gun Violence Archive cited in the New York Times, right, which is just a team, right, that looks up media articles and kind of calculates how many gun injuries are. That's how bad it is. So we need that data. I love the part about storytelling. I would say advocacy also means not just talking to politicians, because there has been a sense that, no matter how much data we present, when you talk to politicians, sometimes it matters, sometimes it really doesn't. Advocacy also means you can use that data to talk to corporations and big businesses in your community, because they can make a big difference and they can be great lobbyists and activists alongside with you. So just add that.
Thank you so much.
I'm going to turn it over to Dr. Ding for closing remarks. And again, they'll be here for you guys to ask questions too. So don't leave. They will be here. We have to run, but they will be here.
Wow. Well, thank you all for joining us today on this session. I also want to express my gratitude to our esteemed speakers, not just for their exceptional collaboration and insightful contributions to today's panel discussion, but really for all of their work on the task force. So in this session today, we've delved into some crucial questions surrounding counseling patients on firearms, interventions, including secure storage and ERPOs. We've learned about the business case for how to invest in hospital-based violence intervention programs, which really can bridge that gap between healthcare institutions and the local communities to addressing those root causes of firearm violence. So clearly, there are multiple ways in which we can tackle this public health crisis in this country, and we do need to continue to work toward even more comprehensive plans and solutions. So Drs. Abaya, Betts, Hoops, Sathya. They've really shared their wealth of knowledge and expertise, and we are so fortunate to have them amongst the experts on our AMA's Firearm Injury Prevention Task Force. Now, as our AMA convened task force continues its work, we hope that we will stay engaged, we hope that you will stay engaged and interested in this work, and we look forward to continuing to share our progress on this task force with the House. And I just want to emphasize the tremendous collaboration, the expertise, the advocacy that we've been able to lean on with all of our task force members. I think it's just another example of how the AMA can serve as an important convener, and how when we work together in the House of Medicine, we truly are stronger together. Now, each of you here is undoubtedly committed to enacting meaningful change and advocating for firearm injury prevention. And we hope that this panel has really equipped you with greater confidence in a number of these issues. We also hope that you'll share some of these resources you've learned about today through the National ERPO Resource Center and the HVIP with all of your colleagues. But I think let's not stop there. I think I'd really love to see you take this knowledge that you've gained today, applied in your respective spheres of influence, advocate for the implementation of HVIPs in your healthcare institutions, initiate those conversations with your colleagues, community leaders, about the importance of firearm injury prevention. And as you've heard multiple times today, use those stories, tell those stories. As physicians, there are a number of things we can do in the clinical space to help our patients, but everyone here, we are also advocates, and there are things we can do outside of the clinical space. And so let's make sure that we don't forget that we've got both of these areas in which we can make important impacts. So thank you again for joining us today, and thank you again to this fantastic panel.